Hello, my name is Amit Pawa and thank you for joining me for this talk on nerve blocks for trauma, which I originally delivered at the London Trauma Conference in 2022. My disclosures remain the same and none of them will impact on my ability to deliver this talk, but I will again point out the Complete Anatomy app from 3D4 Medical, which I will use to demonstrate much of the anatomy. So I was asked to present 3 questions, and those questions are: what blocks are most effective? How difficult are they to learn? And how long can they last? And I have 20 minutes in which to deliver that, so let's get started. First of all, what blocks are most effective? If you look at all of the possibilities in trauma, there are many opportunities that present themselves for regional anaesthesia, with fractures of long bones where interscaling may have a role, and also brachial plexus, and dare I say the Beers block. If you look at the lower limb, of course, you've got other techniques involving fractures of the lower limb, where the femoral, fasciitis, and Peng block may have a role, and further down, looking at blocks of the ankle or the sciatic nerve. If you look at the thorax, of course, there are many opportunities with vertebral fractures, possibly controversially the use of Erector Spinae plane, and then sternal fractures, the role of the parasternal intercostal plane blocks, and then rib fractures produce a large number of opportunities that we could perhaps consider. Then there are other sort of non-bony type injuries where other fascial plane blocks may have a role. So clearly, all of these have a role where regional anaesthesia may be able to make a difference. But there is one caveat, and that's if you imagine a situation like this where there's a significant long bone injury, it's important to consider neurology and be aware of the risk of compartment syndromes to discuss with your surgical and your neurosurgical teams and orthopedic teams before placing a nerve block. So I presented a number of options. How am I going to choose which of those situations to discuss within the 20 minutes? And I've decided to talk about regional anaesthesia for fractured neck of femur, and I've also decided to talk about regional anaesthesia for rib fractures. So you might ask, why am I talking about these two? Well, they're both common pathologies. They're associated with a large amount of pain, and they have morbidity and or mortality associated with them. There's a risk of respiratory depression, which can be exacerbated when opioids are used, and often they may present in older patients, and either the pathology themselves or using opioids to treat them may be associated with a delirium risk. So, regional anaesthesia may have a meaningful impact here. So what blocks am I going to cover? I'm going to cover the Supra-inguinal fasciitis block, the Peng block, Serratus anterior plane block, and the Erector Spinae plane. So, how difficult are they to learn? Before I go into more detail of how to block, it's important that we revise some of the innovation because that may well be relevant in understanding which blocks to choose. So let's start off by looking at the fractured neck of femur and the relevant innovation. If we look at the anterior hip innovation, there are 3 nerves that are very important: the femoral nerve, the obturator nerve, and the accessory obturator nerve. What about the posterior aspect of the hip? Well, there are another few nerves to think about here. We've got the sciatic nerve, the superior and inferior gluteal nerves, and the nerve to quadratus femoris. But you'll notice a lot of the time we focus attention at the anterior aspect of the hip. And again, I've just changed the femoral nerve to look at the articular branch of the femoral nerve now. But we can look at a bit more detail here and look at the quadrants of hip. And actually, you can see if the different quadrants are differentially innervated. However, the femoral nerve is important, seeing as it has contributions to all quadrants of the anterior aspect of the hip. So let's move on. If we look at the femoral nerve and the supra-inguinal fasciitis block, let's look at the anatomy that's relevant. We'll have a look here at one of these 3D4 illustrations, and we'll zoom in here. I'm going to highlight the sartorius muscle first, with a lateral femoral cutaneous nerve overlying it, the iliacus muscle and fascia, and the psoas, and there's the internal oblique. We zoom in a bit further, there's a femoral nerve, the femoral artery, and the profunda femoris, and the femoral vein. We'll zoom in even closer now, and there is the deep circumflex iliac artery. That will be relevant later, but if I zoom in as if we were looking at a supra-inguinal fascia iliaca view here, you can see the iliopsoas muscle diving deep down into the pelvis associated with the femoral nerve, and the deep circumflex iliac artery overlying the femoral nerve in that particular view. So if we were to start off at the femoral nerve, what might you look at? Well, what you might look at is a view here where you've got the iliopsoas muscle, the sartorius muscle laterally, and then the femoral nerve lying on the body of the iliopsoas muscle, often invaginating the area there. You can clearly see the femoral artery. So here's a rough idea of the sonoanatomy relevant to this. What happens if we were to place a probe on? Well, if you place a probe on this area and remove the fascia, this is what most people do. They place the probe where there's a branch of the femoral artery already. They've got the femoral artery in the profunda. So let's slide up. So you've got a single femoral artery with a femoral vein medially. And as we slide laterally, you can hopefully appreciate the body of the iliopsoas muscle. And there is a hyperechoic structure literally sitting right on the surface of the iliopsoas muscle. As you slide the probe laterally, you'll see sartorius just coming into the view. But I said I was going to talk about the supra-inguinal fascia iliaca block. And often when we talk about that, we talk about a bow tie appearance. So what am I talking about? So before we go into detail, just to talk about the fact that when you're doing a supra-inguinal fascia iliaca block, you're aiming to target the femoral nerve, the lateral femoral cutaneous nerve, and the obturator nerves, and this has been demonstrated to be superior to the classic infra-inguinal approach. So let's look at this bow tie. This is the kind of bow tie that we're talking about, overlying the pelvic brim. Let's show you what we mean by that. So you can see the bow tie is made up from the sartorius and the internal oblique being two angles of the bow tie, and the iliopsoas muscle being the central component. And you'll also notice I've highlighted the deep circumflex iliac artery. When you perform a supra-inguinal fascia iliaca block, you're going to pop your needle in here, deposit local anaesthetic, and lift that deep circumflex iliac artery up out of the way, showing that you're in the right area. So what may it look like when you try to generate that image? So here's an image over the femoral artery and the femoral nerve, sliding laterally over the iliopsoas and the sartorius. If I rotate the probe around and slide cephalad towards the abdomen, you'll notice the internal oblique coming into view. There's sartorius, iliopsoas, the internal oblique, and you can just about identify the deep circumflex iliac artery lying in that area. I'm very lucky that one of my colleagues, Jeff Gadsden, has shared a video of the supra-inguinal fascia iliaca block taking place. So here we go. Here's the needle coming in from the caudad aspect, aiming to pop through the fascia iliaca, and as you inject local anaesthetic, you're going to watch for this classic unzippering view there. You can see that unzippering and local anaesthetic diving down in towards the pelvis to get the proximal aspects of the lumbar plexus. So thank you, Jeff, for that video. So let's summarize supra-inguinal fascia iliaca block. Generally speaking, we have a patient supine. We tend to needle in plane. You can use your transducer type according to the patient's body habitus, but it tends not to need a very long needle. And if you're going to place a catheter, 3 to 5 centimeters maximum to be included in there. And we tend to use large volumes in this plane, so 30 to 40 mils. It's really important to make sure your needle is deep to the fascia iliaca and below the deep circumflex iliac artery. And you've got to make sure your needle is cephalad to the pelvic brim to stop local anaesthetic from spilling backwards. So what about motor sparing blocks? Well, do you remember the innovation we talked about? Let's revisit that. So here we've got the articular branch of the femoral nerve, the obturator nerve, and the accessory obturator nerve. So of course it's now Peng block time. So what does Peng stand for? The pericapsular nerve group with the group that invented it, but also one of the authors of the paper was Professor Philip Peng. Let's look at the anatomy. So we're going to zoom in now and look at this sort of peeled away anatomical component of one side of the lower limb. And I'm just trying to highlight the anatomical appearance of the anterior superior iliac spine, the anterior inferior iliac spine, and the pelvic brim. There's the psoas muscle coming down to a tendon as it lies on the pelvic brim over the iliopubic eminence. You can appreciate now, hopefully, the iliacus muscle, the psoas muscle forming a tendon, and that classic appearance there, the anterior superior iliac spine, the anterior inferior iliac spine coming down onto the pelvic brim, or the superior pelvic ramus, or pubic ramus, sorry, and the iliopubic eminence. So what are the sonoanatomical landmarks we're looking for? So if you were to place a curved array probe in this area, you get to see here the iliacus muscle over the anterior inferior iliac spine, the iliopubic eminence, and the psoas tendon. And note you can see the femoral artery and the femoral nerve on the medial aspect of the image. What we haven't showed here is the lateral femoral cutaneous nerve, as it may lie on the lateral aspect of the image. So now let's place a probe, and we're going to trace down from the anterior superior iliac spine along a line connecting the anterior inferior iliac spine and the iliopubic eminence. So let's see what might happen here. So there's the anterior superior iliac spine, anterior inferior iliac spine, and now we're going to slide down to get the superior pubic ramus. And as we come across, I'll get the iliopubic eminence in view there, and you can there see the psoas tendon as a circular hypoechoic structure lying on the superior pubic ramus, with the femoral artery lying medially. Now, it's not always easy to generate a view this way, so if this is tricky, you could simply scan up from the femoral head. What do I mean by that? Well, here we go. We plonk the probe on the femoral head, you can see it there, and slide up, and you generate that view. So that's that classic sonoanatomical view. So what may a Peng block look like? Well, here we go. Let's notice the needle coming in from lateral to medial, taking care to avoid the lateral femoral cutaneous nerve and the femoral nerve and artery medially, aiming to pop your needle underneath that psoas tendon. As you get to that region, sometimes you can use a little corkscrew maneuver with the needle to get deep to the fascia, and as you inject local anaesthetic, you want to see that psoas tendon lifting up and out of the way. So injection of local anaesthetic is about to come now. As we're injecting local anaesthetic, you're going to start to see that psoas tendon lifting up and out of the way. It's a very subtle injection there. Doesn't require a large volume, but we're aiming to see, as we inject local anaesthetic, there's the needle going in that area, small aliquots of local anaesthetic lifting the psoas tendon up. So let's summarize the Peng block. We tend to have the patient in the supine position, and although you can use an out of plane, in plane makes sense. We tend to use a curved array probe, or at least a linear probe with a curved array function, to improve your field of view. Maybe need a slightly longer needle, and it only needs 15 to 20 mils of dilute local anaesthetic. It's important to make sure you visualize the femoral nerve to avoid it. Take caution with inserting the needle at the lateral aspect of the screen to avoid the lateral femoral cutaneous nerve. Aim to contact bone, but avoid an intramuscular injection, because if you inject intramuscularly, there is a chance you may get a motor block from the femoral nerve. So let's summarize here. The femoral or supra-inguinal fascia iliaca nerve block involves injecting local anaesthetic and directing that local anaesthetic in a cephalad orientation, and Peng block involves coming from the lateral aspect and injecting local anaesthetic in that sort of orientation. Okay, what about regional anaesthesia for rib fractures? Well, we can't talk about this without talking about my pet favourite subject, which is, of course, chest blocks. And what are the chest block options? Well, before we get there, we're going to talk about innervation. So if you imagine you've now got your dorsal and ventral ramus coming out to form the spinal nerve, and whilst it communicates with the sympathetic chain, there is of course a dorsal ramus and a ventral ramus that comes up and gives you a lateral cutaneous branches and anterior cutaneous branches. So of course there are many nerve block targets that can come from here, but if we focus on the big five, we've got thoracic epidural, thoracic paravertebral, the intercostals, the erector spinae plane, and the serratus anterior plane. And I'm going to focus on what I've called the topical two, the erector spinae plane and the serratus anterior plane. And of course, don't forget we can use catheters here for local anaesthetic infusions. Let's start with the serratus anterior plane block. If we zoom in here under pec major, you can see I've kind of faded serratus, so you can just see the anterior digitations there. As we zoom in and look under pec major, you can see pec minor just in the distance. You can see the thoracodorsal artery, the long thoracic nerve to serratus anterior, and the thoracodorsal nerve. And you can also see the anterior cutaneous branches, the lateral cutaneous branches of the intercostal nerves just coming out over here. So you can imagine how local anaesthetic deposited either above or below serratus anterior would catch those lateral cutaneous branches of the intercostal nerves. This is the type of sonoanatomical image you may get here with a probe placed over the lateral aspect of the chest. You can see you've got lat dorsi superficially over serratus anterior, and serratus anterior hugs those ribs. And in between lat dorsi and serratus anterior, you can see here the thoracodorsal artery along with the nerve. So let's imagine what it may look like to scan. So we place a probe on that lateral aspect. Again, here's that classical sonoanatomy, and I'm going to remove those highlights. You can see here the probe is now moving posterior. You can see that tip of LD come anterior a little bit more and posterior, and you can see as I slide up and down the different muscle fibers that are traveling in different directions, allowing you to delineate those two muscles. And you can see the pleura deep to those muscles there. So this is an example of a superficial serratus anterior plain block where local anaesthetic is injected between LD and the serratus anterior muscle. You can see that nice unzippering over there. And as you inject local anaesthetic, you see that space open up, so you can tell you're very much in the space. Here's an example of a deeper plain block, so local anaesthetic injected deep to serratus. You can see the rib on the left-hand side of the screen and the pleura deep to that, and how that local anaesthetic is lifting the muscle up out of the way. Now you can, of course, identify a rib in long axis, and these images thankfully donated by Arun Nugdev. You can see on the left-hand side of the screen a rib is scanned in long axis, and you can see a step in the rib. And here on the right-hand side of the screen you can see a local anaesthetic injection in the superficial plane at another rib level. You can see how that opens it up. You can, of course, also identify a rib fracture in short axis, and here's a short axis view of a rib fracture, and here's now a deep serratus anterior plain block being performed at the same level as that rib fracture. You can see local anaesthetic contacting the rib to lift serratus up out of the way. So, with the serratus anterior plain block, let's summarize. You can have the patient in the supine or the lateral position. I tend to recommend in-plane needling, and again the transducer type is dictated by body habitus. The needle length can be anywhere between 50 to 100 millimeters, and you can decide to inject above or below the serratus anterior muscle. We tend to use a large volume again here, so 20 to 30 ml as a bolus, and then we would use an infusion with a basal rate plus or minus a patient administered or automated bolus function. Be careful when you're injecting in the superficial plane to avoid the thoracodorsal vessels, and also beware to identify the nerve that may lie there, and also the pleura, especially if you're doing a deep block. In order to minimize wastage of local anaesthetic, you could consider using a Sika solution of a non-active solution, so you don't waste your local anaesthetic. Let's move on to the Erector Spinae plane now. So here you can see we've highlighted the trapezius muscles, rhomboid, and if we go deep to that, the three components of the Erector Spinae muscle group. And if we zoom in a bit more, you'll see when we're aiming to do an Erector Spinae plane, we're aiming to inject deep to those muscles, superficial to the transverse processes. By doing a block this way, it's likely that you'll block the dorsal ramus, and we can see that because as you zoom in a bit here, you can appreciate the dorsal rami comes out and lies in close proximity to that plane where you're injecting close to the transverse process. So dorsal ramus block makes sense. What about the ventral ramus? If we remove the lung and zoom in here, you can look at the paravertebral space from the inside out. You can see the superior costo-transverse ligament and the ventral ramus of the spinal nerve, or the intercostal nerve. That's the ventral ramus highlighted. But look, the dorsal ramus communicates and exit via that medial slit. So it is possible that local anaesthetic injected posterior to that in the retrosuperior costo-transverse ligament space may actually track down towards the paravertebral space, but we'll leave that for another lecture. So, what sonoanatomical landmarks may you see here? Again, we've highlighted the issues here with trapezius, rhomboid, and erector spinae muscle lying superficial to the transverse process, with the intertransverse complex, and deep to that the pleura. So this is the pattern recognition you're aiming to identify. What may it look like if you try and generate that scan? Well, let's have a look. We'll zoom in, we'll remove the skin, we'll place a probe at the rib level, and then we'll slide towards the midline. You'll notice the ribs go down, and as the ribs go down, you'll see a muscle bulk above them get thicker. That's the erector spinae muscle complex. The bony architecture changes. Those are the transverse processes. Let's slide laterally again to ribs and back towards the transverse processes, and there at that point you can see that thick classical erector spinae muscle, which is a tip that you're at the right place. There's the overlay, and you can see that thick erector spinae muscle bulk. So what does a block look like? Here's a needle coming in, and as the needle comes in, you can just about make a highlight of the transverse processes there. As we're injecting, you can see the erector spinae muscle bulk lift up. Injecting local anesthetic, it lifts up out of the way. As we increase the depth, you can appreciate how far away you are from the pleura. You can see a nice space opening up deep to the erector spinae muscle. So let's summarize the erector spinae plane. So again, we tend to do it in sitting, prone, or the lateral position. You can needle in or outer plane, and the transducer type is dictated by the patient's body habitus. Tends not to need a long needle, and again, if you're going to place a catheter, 3 to 5 centimeters maximum. This again is a volume block, so 20 to 30 mils of local anesthetic, and then a basal plus bolus infusion regime via the catheter. I would definitely recommend hydrodissecting with a Sika solution and aim to lift the erector spinae muscle and its fascia up off the transverse processes. And it makes sense to aim for the corner of the transverse process as opposed to aiming for the midpoint of it, because you really do want to make sure you are deep to the fascia of the erector spinae muscle. So if you were presented with a patient with anterior lateral rib fractures, a serratus anterior plane block makes sense. And if you're going to have a patient with posterior rib fractures, it makes sense to do an erector spinae plane block, but you know what? Serratus anterior plane blocks can have a role. The last question is, how long do they last? So when you do these nerve blocks, how long do they last? Well, the bottom line is it tends to be dictated by the local anesthetic that you inject. And as a general rule, the analgesic effect is less than 24 hours. And that, of course, is where nerve catheters have an important role. And nerve catheters are important because they can prolong duration of analgesia, gives you the ability to titrate the block intensity, and a prolonged period where you've reduced opioid reduction. Now, if you're working in emergency departments, you may think, well, how can we do this? Well, you know what? This is a paper back from 2016. And in this particular paper, they had 161 hip fracture patients. They compared them with a block technique or block protocol versus a standard care. And the block protocol involved a single shot femoral nerve block done by the emergency department team. And then within 24 hours, the anesthetic team would put in a fascia iliaca catheter. What was incredible about this study was actually they noticed that the block group had reduced pain and opioid consumption, not surprising, but even as far as 6 weeks later, they had enhanced walking and better outcomes. So the bottom line is regional anesthesia in trauma is worth performing, and it's important to think beyond 24 hours. Here are a number of papers that have been useful with the preparation of this lecture. If you scan the QR codes, you'll get taken to those links to those papers. And now we'll move on to the summary. So to summarize, regional anesthesia has an important role in trauma. For rib fractures, paravertebral and epidural blocks may be the best, but serratus anterior and the erector spinae plane blocks are simple and effective alternatives that may have better reach and actually may be applicable to certain cases where paravertebrals and epidurals are contraindicated. With regards to hip fractures, femoral and supra-inguinal fascia iliaca blocks are simple and hugely beneficial techniques, so worthwhile learning, and the Peng block has a motor sparing effect and is being increasingly used. And whenever you're going to consider these, please do consider using nerve catheters. That concludes the lecture that I wanted to present today, but I also want to highlight there are more videos available on this YouTube channel. Thanks for listening.